Hello, everyone. Testosterone treatment has been approved for the treatment of hypogonadism in men since the 1940s in the United States. So why is there so much controversy about testosterone replacement therapy of men with hypogonadism? To be sure, prior to the advent of had severe hypogonadism. Apparent. Testosterone treatment of such men with severe hypogonadism also was associated with marked changes in their secondary transition, as well as marked improvements in their sexual function. Therefore, there was no controversy about the potential benefits of testosterone treatment in such men with obvious testosterone are 40 to 65 years of age. They're middle-aged or older men who have only mildly low testosterone concentrations, and some even have low normal testosterone concentrations. These men often present with symptoms that have substantial overlap with age-related symptoms. Testosterone treatment of these men is with improvements that are not as clear as those we observed previously in men with severe hypogonadism. The long-term benefits and risks of testosterone replacement therapy in such men are not as clear, and therefore it has led to controversy whether these middle-aged and older men with mild hypogonadism should receive testosterone replacement therapy. The cardiovascular and prostate safety of testosterone replacement therapy has been a source of much controversy and concern for patients, their clinicians, as well as for the regulatory agencies. It is in these issues about the potential benefits and risks of testosterone replacement therapy in middle-aged and older men with hypogonadism that were addressed in the TRAVERSE randomized trial. The patients and their clinicians, as well as the regulatory agencies, worry whether testosterone replacement therapy of middle-aged and older men with hypogonadism will increase their risk of prostate safety events, such as prostate cancer and benign prostatic hyperplasia. Testosterone plays an important role in the biology of prostate cancer. However, epidemiologic studies have not found a consistent relationship between circulating levels of testosterone or dihydrotestosterone and risk of prostate cancer. Mendelian randomization studies of the UK Biobank data reveal that men with higher genetically determined bioavailable testosterone levels had higher lifetime risk of clinical prostate cancer. Similarly, registries of men with Klinefelter syndrome who have lower testosterone levels have reported lower lifetime risk of clinical prostate cancer as well as prostate cancer mortality. Most professional society guidelines recommend avoiding the use of testosterone replacement therapy in men with history of prostate cancer or at increased risk of prostate cancer. No prior randomized trial, however, has evaluated the incidence of high-grade prostate cancer or any prostate cancer in men given testosterone replacement therapy. Additionally, the effect of testosterone replacement therapy on acute urinary retention, benign invasive procedures for benign prostatic hyperplasia, initiation of new pharmacologic therapy for benign prostatic hyperplasia, or on lower urinary tract symptoms have not been evaluated in any large randomized controlled trial. The TRAVERSE trial, because of its large size and long treatment duration, offered an outstanding opportunity to evaluate the effects of testosterone replacement therapy in middle-aged and older men with hypogonadism on these prostate safety events, as well as on lower urinary tract symptoms. The TRAVERSE trial enrolled middle-aged and older men, 45 to 80 years of age, who met the Endocrine Society guidelines for hypogonadism. These men had 2 early morning fasting testosterone concentrations less than 300 nanogram per deciliter, measured using liquid chromatography tandem mass spectrometry, as well as one or more symptoms of hypogonadism. These men were selected because they also were at increased risk of coronary artery disease or had pre-existing coronary artery disease. Men were excluded if they had screening PSA greater than 3 nanogram per ml, had a diagnosis of prostate cancer, severe lower urinary tract symptoms indicated by International Prostate Symptom Score greater than 19, or a prostate nodule detected on digital rectal examination. The eligible participants were then randomized with stratification for pre-existing coronary artery disease to receive a 1.62% transdermal testosterone gel or placebo gel for the duration of the study. Testosterone dose was titrated based on on-treatment testosterone levels as well as hematocrit levels to maintain testosterone concentrations between 350 and 750 nanogram per deciliter and hematocrit level less than 54%. A prostate endpoint adjudication committee adjudicated prostate cancer diagnosis and Gleason score, acute urinary retention events, and invasive prostate surgical procedures for obstructive symptoms. Lower urinary tract symptoms were ascertained at pre-specified regular intervals using international prostate symptom scores. The prostate monitoring plan of the TRAVERSE trial was designed based on the recognition that testosterone treatment increases PSA levels, and that men randomized to testosterone arm are more likely to meet the PSA criteria for urological referral and are at increased risk of prostate biopsy. Because there's high prevalence of subclinical prostate cancer in older men, an increased number of prostate biopsies in the testosterone arm of the trial could lead to ascertainment bias by detecting subclinical prostate cancers in men who had prostate biopsy. We considered this potential ascertainment bias and incorporated several steps to minimize the risk of unnecessary prostate biopsies, leading to the diagnosis of low-grade prostate cancers while retaining the ability to detect high-grade prostate cancers that might increase the risk of adverse health outcomes, including death. So the study protocol pre-specified the following criteria for urological referral: a confirmed PSA increase of greater than 1.4 nanogram per ml in the first year after randomization, or a PSA level greater than 4 nanogram per ml at any time during the course of the study, or the detection of an induration or a nodule during any of the study visits. All PSA elevations were confirmed by repeating the test, and confirmed PSA elevations led to showing the participant an informational video that described the potential risks as well as potential benefits of doing a prostate biopsy. This strategy was successful in reducing the number of prostate biopsies in the TRAVERSE trial. The most important finding of the TRAVERSE trial was that the numbers and incidences of adjudicated high-grade prostate cancer or any prostate cancer were low and did not differ between the placebo and the testosterone arm of the trial. Similarly, the incidences of acute urinary retention, invasive prostate procedures for benign prostatic hyperplasia, or initiation of new pharmacologic treatments for lower urinary tract symptoms did not differ between the two treatment groups. Lower urinary tract symptoms that were assessed using the International Prostate Symptom Score worsened in both groups over time, as would be expected, but did not differ between the two treatment groups. Approximately 8% of participants in each group reported severe lower urinary tract symptoms during the intervention period. Serum PSA levels increased more in the testosterone group than in the placebo group in the first year after randomization. However, the PSA change over time did not differ between the two groups after the first year of intervention. The number of biopsies between the two study arms also were similar. The TRAVERSE trial's findings have important implications for clinicians and men considering testosterone replacement therapy. First, the men being evaluated for hypogonadism should undergo a baseline assessment of prostate cancer risk to identify those who have prostate cancer, those at high risk of developing prostate cancer during testosterone replacement therapy, and those at high risk of being referred for prostate biopsy during the course of testosterone treatment. Second, the clinicians and patients considering testosterone replacement therapy will find it reassuring that in middle-aged and older men with hypogonadism who've been carefully evaluated to exclude those at high risk of prostate cancer, the incidences of high-grade or any prostate cancer and other prostate events were low and did not differ significantly between the testosterone and the placebo group. Testosterone did not worsen lower urinary tract symptoms in men who did not have lower urinary tract symptoms at baseline. Third, a standardized monitoring plan can reduce the risk of unnecessary prostate biopsy and of detecting low-grade indolent cancers while enabling the detection of high-grade prostate cancers that could adversely affect health outcomes and the risk of death. In summary, the TRAVERSE trial, the largest cardiovascular safety trial of testosterone replacement therapy ever conducted, has provided important data on the cardiovascular and prostate safety of testosterone treatment in middle-aged and older men. The men considering testosterone treatment and their clinicians weigh their concerns about prostate cancer risk heavily in their treatment decisions. Therefore, the trial's reassuring findings on the cardiovascular and prostate safety of testosterone replacement therapy will be helpful to clinicians and their patients in facilitating a more informed appraisal of testosterone's benefits and risks in guiding their treatment decision.